Thank you everybody for joining us here today, and a special welcome to those who are joining us outside the university. It's really great to have you here. So my name is Allison Gemmel, and I'm an assistant professor in the Department of Population, Family, and Reproductive Health. And today's seminar is co-sponsored by the Population and Health Area of Interest in the PopFam department, as well as the Hopkins Population Center. We are delighted to have our speaker, Dr. Elizabeth Wrigley-Field, join us today. Dr. Wrigley-Field is a formal demographer and sociologist. She's an assistant professor in the Department of Sociology at the University of Minnesota, as well as a faculty member of the Minnesota Population Center. Dr. Wrigley-Field's research brings formal demographic techniques to the sociology of inequality and sociologically informed concerns about hidden dimensions of racial inequality to formal demography. She has received numerous awards and honors for her research. Today's talk, titled "The Deaths America Treats as Normal: Structural Racism and Racial Disparities in Mortality During the COVID-19 and 1918 Flu Pandemics," showcases her methodological and theoretical approaches to studying how critical events shape population health, both in contemporary society and historically. I hope this talk is especially enlightening for students who may question how formal demographic methods can be applied to public health issues. So with that, take it away, Dr. Wrigley-Field. Thank you.
Thank you so much for having me. I'm going to do two things in this talk. I'm going to show you two very different projects whose link is looking at racism and pandemics. So first, I'm going to show some new research that I'm doing on the 1918 flu pandemic that I want to argue gives us a general framework for thinking about inequality and especially racial inequality during pandemics. And then I want to, I'm going to give just kind of high-level results from that project. Not a lot of methods details. I'll get as detailed as you want in the Q&A. We're super immersed in this project right now, so that's always fun. But I want to then shift gears and talk about how pandemic mortality can give us a different perspective on what's happening in the modern US context today, not just in the COVID moments, but actually all of the time. So first, I'm going to show some research on racial disparities in flu and pneumonia mortality in US cities during the 1918 pandemic. This is work that's being done with a large research team that is co-led by Martin Eierman, who is a fabulous graduate student in Berkeley sociology, and by me. And one of the big questions that is lurking underneath this project is, what can we learn from 1918 for today? And also, what can't we learn, or what can't we extend? So some things about 1918 will feel eerily familiar. Whoops, there we go. So for example, earlier research has found that non-pharmaceutical interventions, which are things like closing schools and theaters, enforcing quarantines, mandating masks, we call those non-pharmaceutical interventions. And those things during 1918 did work to reduce mortality, but not by that much. And the reason is that they generally were not sustained for long enough to have as big an effect as you might suspect. And so why were they not more sustained? Because they met with ferocious resistance. So here's something that we found from a Topeka newspaper article during an archival data collection phase of the project. Both the health commissioner and the health officer have been the target during the last few months for gobs of criticism and insubordination against what was termed the autocracy they were establishing in depriving the citizens of the privilege of freedom of action, the right to mingle with flu germs. So this historical relic is very hard for us to relate to today, I know. But okay, so some things maybe haven't changed as much as you might expect in the intervening century. But there's one very important fact about 1918 that has been underappreciated and is very different from today. So to back up and give some context, the 1918 flu was really distinctive for at least three reasons, and two of those are very well known. It was incredibly deadly, and it also had this really weird age pattern. So usually the people who die of flu are people who are really young and really old, kind of a U shape. But the 1918 flu was more of a W shape, where young adults, people in their 20s and 30s, were actually hit incredibly hard. The third really weird thing about the 1918 flu is not so well known. So against a backdrop of really extreme racial inequality in every other year of that era, and I'll say a little bit more about that, the disparities in 1918 were surprisingly small. And this actually was known at the time, as this quote makes clear. This is the Reverend Francis Grimke, a kind of prominent Black minister, who said, during these terrible weeks while the epidemic raged, God has been trying in a very pronouncedly conspicuous and vigorous way to beat a little sense into the white man's head, has been trying to show him the folly of the empty conceit of his vaunted race superiority by dealing with him just as he dealt with the peoples of a darker hue. Okay, so it was understood at the time that something very unusual was happening, which is that the white population was being hit very hard by the flu, when normally the flu was very aggressive and deadly for Black populations in particular. And these small disparities are analyzed in a small amount of research, which are kind of shown on the right side of the screen here. But it's mostly actually been forgotten in the story of 1918. So we started out by just providing the first description of racial disparities in flu deaths for every US city that collected any race-specific data. This shows the results. These are non-white to white flu and pneumonia mortality ratios for cities from 1910 to 1921. So when these are larger, there's more inequality. In this era, non-white, especially in cities, almost always meant Black. There's just a couple of exceptions in the Southwest where that wasn't true. And what I want you to see here is that, first of all, these 1918 disparities are far smaller than all other years. And second, there's also extremely little variation in them. So they were sort of uniformly small. And this is happening because the 1918 flu raised non-white mortality by a factor of 3, right? So it's really incredibly deadly, but it raised white mortality by a factor of 5. And these small aggregate disparities are really driven by small disparities in those crucial young adult ages where mortality was really concentrated. So essentially the relatively limited racial inequality in 1918 is happening because white mortality in the 20s and 30s is so extreme. So we want to understand why this is happening. We consider a lot of different candidate explanations. So for example, when we started, we thought that those non-pharmaceutical interventions that cities undertook, things like the kinds of lockdowns we've had sometimes today, school shutdowns, theater closures, mask mandates, all of that, we thought that might account for the small disparities. And this idea makes sense. The NPIs certainly were unique to 1918. They were not undertaken in other years. Past research has shown that they did matter. And while the public health responses that were organized by cities were typically quite racist, for example, cities opened clinics and hospitals for whites only during the pandemic. And they did that in both northern and southern cities. But by this time, there were also fairly robust networks of Black municipal reformers who were positioned to push back against that. And we also thought that even if cities were only really politically responding to the epidemic for whites, they might have ended up disproportionately helping the urban Black population in the same way that we know from the economic historian Werner Troskin's work, sewage systems did in the South, just because the Black population otherwise was at such extreme risk because the conditions of their life were so extremely poor in cities due to racist segregation and immiseration. And so, long story short, we used historical newspaper records to find the timing and the duration of these non-pharmaceutical interventions in 52 cities where we had also found race-specific mortality data. And like other studies, we found that these generally did reduce mortality, but they did so across the board. There's no association with disparities because they have the same kind of effects for white and non-white populations. We found the same kind of thing for other city level traits like segregation, the city's proximity to military bases, air pollution. Military base proximity and air pollution are both associated with higher mortality in 1918 In the case of military bases, it's because that facilitated the spread of the flu as troops moved around during World War I. But they're associated with mortality about equally for white and non-white populations. None of these seem to account for the variation across cities at all. We don't think they're explaining the variation across years. And so what we had started exploring is a different kind of explanation. The urban white and non-white populations in 1918 had very distinctive social histories. The white population was spread all around the country. It included many born in the United States. Many of those had been born in cities in the United States. And then especially in the Northeast and the Midwest, it also included many immigrants. The non-white population was disproportionately Southern and disproportionately Black internal migrants, people who were born into deeply impoverished agricultural settings who then migrated to cities, first in the South and then also in the North. And once in cities, they were made by law and by violent force to live in truly appalling conditions, just intensely crowded and dilapidated. So rural origins, but then living in the worst that cities had to offer. That's a very particular life course history of exposure. And these distinctive exposure histories offer the possibility of explaining the small racial disparities in 1918 through the interaction of this social history of each racial group with the natural history of the 1918 virus. And so what do I mean by that? The details of these 6 distinct social immunological hypotheses are really complicated. I will not get into them in the talk. But the basic story here is actually quite simple. Non-white people were either more likely to have had an earlier flu exposure that was protective, or they were less likely to have had an earlier flu exposure that was harmful. And the details of these hypotheses trade on 2 very distinctive biological features of the 1918 virus. One is that 1918 had a relatively mild spring wave before evolving to become more virulent and deadly, and then had an extremely deadly fall wave in 1918. That's when almost all the deaths happened. And that means that early exposure to the less deadly spring wave could have conferred a kind of partial immunity. And so to the extent that non-white populations were more likely to have that early exposure because of the really dangerous conditions that they were forced to live in cities, they might have actually been somewhat protected when the virus evolved. This is the only hypothesis in the existing literature about racial disparities in 1918. It was put forward by the historian Alfred Crosby, but it hasn't really been tested in any way before. The other really distinctive feature is that the 1918 flu happened to have some combinations, according to our best guess about what the 1918 flu actually was, right? Which is based on these sort of like historical phylogenetic analyses and other kinds of analyses, because we don't have biosamples to actually know. And by we here, I mean everyone, right? So we're not doing the historical phylogenetic work, but the research community's best guess about what the 1890 best guess was is that the 1918 flu happened to have some combinations of antigenic similarities and differences to this very aggressive flu that circulated around 1890, which is sometimes called the Russian flu. And that's the one that we don't know exactly what it is, but we make guesses. And so that means that people whose first flu exposure in their early childhood was to this 1890 flu, they might have actually been especially susceptible in 1918. So essentially the idea is that if you were first exposed as a really little kid to that 1890 flu, your body then might have been primed to react to that flu. And when you encounter 1918's flu, your body floods you with an immune response that is not capable of defeating the 1918 virus, but can crowd out a more productive immune response while also actually doing a great deal of tissue damage, like lots of inflammation, kind of cytokine storms that seem to be what a lot of people actually died of. So this hypothesis was developed by people like Michael Waraby, Alan Gagnon, as a way to explain the very high mortality of young adults in 1918, because they were exactly the right ages to have had this early exposure. But we think it also implies that urban non-white communities that disproportionately did not grow up in cities, but grew up in those rural areas might have been relatively spared this harmful exposure, while the urban white population, who did usually come from big cities for their whole lives, was more exposed. So I'll give you just a high-level summary of these results, starting with that potentially protective spring wave. We found that in 1918, cities that had had a worse spring wave had a lower fall mortality than we'd predict only for non-white populations. And so maybe that's protective immunity that's only detectable at really high levels of population exposure. But basically the core relationship that we would expect to find if this explanation is right, we don't find it in total, we don't find it for white populations. We also think that this kind of negative relationship between you have a worse spring wave and then you're more protected in the fall, finding only for non-white populations, we think that might actually reflect a behavioral response where communities who had already experienced the virus as deadly were more likely to embrace social distancing. And there's some like very kind of sketchy and anecdotal support for that, just in the fact that Black newspapers seem to have actually taken the flu seriously and reported on it and were important in urban Black communities at this time. So I'll say just a little bit more about the idea that early childhood exposure to this 1890 flu could have produced those cytokine storms in 1918 through a mechanism called immunological imprinting. It's worth saying that our method here is we are not going to have any single grade test of these hypotheses, like not even close. But what we're trying to do is think hard about what they imply in very different domains of data and then sort of triangulate. So that's what we do. And specifically, we come up with 5 things that we think would all have to be true for the 1890 imprinting to explain the small disparities in 1918. The disparities would have to be driven by the right cohorts to have had these exposures. Urban non-white members of those cohorts would have been less exposed than white members. Early exposure would have been associated with more mortality in 1918 in cities. There would have had to have been enough early exposure to have this effect, and it would have had to be sufficiently harmful. And we can only offer limited tests of each of these, but we do our best to test them all using a mix of empirical analyses and simulations that we try to calibrate against what is known about historical flu parameters. And specifically underlying these 2 claims are assumptions in 2 domains that we exploit. The differences in how many white and non-white urban residents were born in urban areas as opposed to rural areas, because in urban areas, they would have had more flu exposure. And also how wide or narrow is the range of cohorts that might plausibly have been imprinted in the 1890 pandemic, and what does that imply about the age effects that we should expect to see in 1918? So just as an example, one question we try to answer is, could that huge jump in young adult mortality for whites compared to surrounding ages plausibly be driven by immunological imprinting? Just how big would the imprinting effects need to be for that to work out? And the answer is it would have to be a really, really big effect unless imprinting were close to ubiquitous in the white population. And so then we ask, well, is it plausible that this imprinting mechanism was basically happening to the vast majority of white people in these cohorts? And so we back out how high would the historical flu transmission rates need to be to produce such high imprinting levels in these cohorts. And at the low ends, they're actually not crazy. So they're in line with what we think we know about historical pandemic flu attack rates. So basically the upshot of all these analyses that I just blew my way through very quickly is that we made these 5 attempts to knock this hypothesis down, and none of those attempts succeeded. So this immunological imprinting idea, this is kind of our best explanation left standing, along with that idea, that kind of suggestive idea of distinctive behavioral responses to the spring wave in 1918. But stepping back from these details, the immunological imprinting hypothesis is interesting to me because it offers the possibility of a consilience between these three distinctive facts about 1918. If it's about these really early childhood exposures, then we potentially have a way to explain some of the extreme virulence, the weird age pattern, and the surprisingly small racial disparities all together as a package. That said, I don't think we're going to have a kind of definitive answer to what's right here, right? We're sort of offering a base of evidence for future work. And what I want to emphasize here and close is the framework that this gives us, which is that what happens in a pandemic reflects what was happening before the pandemic, but it only does so mediated by the pandemic's specific biology. And to me, this is really a cautionary tale about reading 1918 forward and assuming that there's some kind of universal path of pandemics that we're on today, or that all pandemics interact with social inequality and reproduce inequality in the same ways as each other, or for that matter, even that racial group boundaries have exactly the same meanings today that they did a century ago. They probably don't. And so the social immunology framework suggests that drawing historical analogies requires us to be really attentive to the details and just very careful in understanding how the particular social histories of a population intersect with the particular natural histories of microbes. So now I want to shift gears into the second part of this talk and give you a different perspective. And to do that shift, I want to start with something that really changed the way that I understood the 1918 flu when James Feigenbaum, Chris Muller, and I found it a couple of years ago. So this graph shows urban infectious mortality across years for whites. 1918 is almost literally off the charts. And yet, that huge spike in mortality for whites, that was still less than the infectious mortality that urban Black populations of that era experienced every single year. When James, Chris, and I first found this, we assumed we'd made a mistake. We looked at the data lots of different ways, lots of different segments of the data, lots of different methods, definitions of infectious mortality, adjusting for age, not adjusting for age, so many different things. It turns out that it's true, and it's not just true in infectious mortality, but it's true in total mortality as well. White mortality during the 1918 flu was less than Black mortality was almost every single year until the 1930s. And the white population's life expectancy in 1918 was still higher than the Black population's life expectancy had ever been. Way back in May 2020, I started wondering whether the same thing would turn out to be true in this pandemic. Racial inequality in mortality is still extreme. The best ever Black mortality and life expectancy in US history. So these are these light blue dashed lines show you the best ever levels for the Black population. And they're similar to levels that whites experienced 20 or 30 years earlier. So one way to think about the size of this racial disparity today is it's as if the Black population has simply been denied 2 or 3 decades of mortality progress. And so I asked, well, how does the size of this gap between white and Black populations today, how does that compare to COVID mortality? Specifically, how many excess deaths among whites in the COVID-19 pandemic would it take to raise white mortality to the best ever Black levels? And I found that to raise white 2020 mortality to the lowest ever Black levels would take at least 400,000 excess white deaths in 1 year, and perhaps 1 million deaths for white life expectancy to fall to the lowest ever Black level, to the best ever Black level, which is the highest. For comparison, official COVID counts put the total COVID deaths in 2020 to all racial groups at about 375,000. Now, everyone agrees these are too low because there were COVID deaths that never got counted as COVID deaths. But we disagree about how too low are they. And we're going to be arguing about this for a long time. But my best guess is that we're going to eventually settle on estimates of white deaths from COVID that were somewhere around the 300,000 to 350,000 range, which is a lot higher than I was expecting when I started this project in May 2020. But nevertheless, this is telling us that even if the Black population had been hypothetically immune to the coronavirus, it probably would still have had higher mortality in 2020 than the white population did in actuality during this pandemic that we have suffered through. When I did this project, I saw it as a way to denaturalize a social fact, which is extreme mortality disparities that we often take for granted. As a mortality demographer, my entire job is counting deaths. And I'm very interested in seeking out metrics that try to translate deaths from just statistical measures into more human measures that we can grasp in a different way. So for example, lately I've been trying different ways to understand what the racial disparities in COVID mortality itself amount to. So in what I just showed you, I used COVID mortality for white people as a metric to show just how vast the Black-white inequality is in non-pandemic times. Now I'm going to go the other way around and use the Black-white mortality difference in the pandemic to tell you something about how big COVID mortality is in the Black population. And so this means the first number I'm now going to give you has nothing to do with COVID. I asked, if we counterfactually assigned the Black population to have white pre-pandemic age-specific mortality rates, how many lives would be saved compared to Black pre-pandemic rates? So this is kind of the inverse of the question that I showed before. The answer I got is about 75,000, which, to put it in perspective, is just slightly larger than the number of Black people dying of cancer every year. So you could think about if preventing the excess deaths that happen before there's ever a pandemic, just year in, year out, the extra deaths that the Black population experiences, preventing that would be like curing cancer. You should also know that this number is artificially low. This number comes from using the age distribution of the Black population as it currently exists. But the Black population is very young because its mortality is very high. And so that 75,000 fewer deaths is what you would get if you had a 1-year blip of white mortality levels after a long period of much higher mortality. It's kind of ironically a much smaller number of deaths than you'd get in a steady state low mortality scenario. But let's go with this artificially low number. And let's say that in non-pandemic times, we're talking about 75,000 excess Black deaths per year, as though we'd cured cancer. Now, how does that compare to COVID deaths? We still do not have our final excess mortality numbers for 2020. We have some provisional ones. Based on some estimates that involve applying earlier data kind of across the year and some adjustments, it would imply maybe something like 120,000 excess deaths in the Black population from the pandemic in 2020. More than cancer, more than the deaths representing the Black-white inequality in a typical year. So what I hope that you've taken from this comparison is just the scale of the utter catastrophe of this pandemic and how heavily it has fallen on Black populations in the United States. And now I want to back up and return to that main result, that it would take about 400,000 excess white deaths in a year to match Black mortality in the best year to close this gap. What does that tell us? Pandemics are special because they are intimately linked to social action. We haven't done a fraction of what I think we should have done to stop this pandemic and to make stopping it survivable for much of this population, with real support for staying home, real protection for those who could not, with different approaches to vaccination that would have prioritized people who were actually at the highest risk. By the way, I'm not talking about vaccines at all in this talk, but I do work on that both on a research side and also in a more applied capacity. And so I'd be happy to talk about that if you want. But more robust workplace protections, we can imagine a lot of things that could have happened and didn't. And it's also true that from the perspective of early 2020, what we have done to stop this pandemic is staggering. And I think what stands out most to me is just the speed with which we were willing to change our assumptions about what is a reasonable change in order to prevent COVID deaths. So for me, it was about 10 days in March 2020 that upended all of my assumptions about what the next 2 years of my life would look like. I think that's pretty common. So it can feel astonishing how little we've done, but from the perspective of just 2 years ago, it's astonishing how much we were willing to embrace change and give up. And to me, that poses the question, what if we were as serious about stopping deaths associated with racism as we are about stopping deaths associated with pandemics? In the last maybe 7 years, one radical response to racism has entered the mainstream of discussion. I'm talking about reparations. These proposals focus on a common lever for redressing American inequality, and that lever is wealth. So for example, Darity and Mullen offer these detailed proposals for congressional committees to estimate the wealth that was lost by individuals due to slavery, while Catherine Frank argues for community land trusts to be created as compensation for land that was stolen after the formal end of slavery. The details of these proposals are very different, but the target of them is the same, it's wealth. And that makes sense because there is no single greater proxy for power than wealth. African Americans were enslaved to create it. Indigenous peoples were dispossessed to take control of it. Nothing else confers as much power and control. So wealth has to be a centerpiece of any form of redress for racism. And yet, grappling with the magnitude of inequality in American mortality, this pandemic's worth of needless deaths that happens every single year, has also made me wonder about what other levers might be needed as well. If wealth is the best single proxy for power, then I would argue that time, how much we get, how much control we have over it, might be the best single proxy for freedom. And as much as the normal operation of our society is built on stealing wealth, so it is also built on stealing time, a theft that was just as central to slavery, the theft of labor power. Today, that theft looks different. It's the loss of time to work without autonomy, scheduled unpredictably, located far from the neighborhoods where Black workers live. It is the cruelty of administrative burdens imposed on poor people to access social services. It is the staggering losses of incarceration. And amid all of these losses and all of this theft, I want to argue that this loss, this theft is also very distinctive. Losing time to death is a distinctive harm because of the way that the meanings that we make in our lives unfurl in time. So here's what I mean. Death means the loss of connections, which are losses that reverberate for others. It means the loss of our effects on the world, the losses of our personal projects. It means losing the chance to see our loved ones and ourselves at different life stages, to let our ideas unfurl in time, and to develop the synthesis of wisdom. And because we're social creatures and creatures that learn so well, aging gives us different kinds of perspectives on the world. So I think it's not just a cliche to talk about aging bringing the possibility of wisdom. I think it's actually reflecting something very deep about the kinds of organisms that human beings are. And so cutting all these lives short is also a huge cultural loss. And I have to admit that I always feel a little ambivalent talking about it that way, because I never want to detract from the fact that the biggest and the most profound loss of a preventable death is always to the person whose life was taken. But I also think it can be important to name the harm fully. These early deaths are robbing all of us of the effects that the people killed too soon should have had upon the world. The things that make for a meaningful life get their meaning from how they extend over our lives and our loved ones' lives. And so cutting someone's life short is robbing them and their loved ones of that meaning. And so working underneath these statistical disparities are all of these most human harms. Would these losses be solved by wealth-based reparations? Perhaps. I suspect that wealth-based reparations would do more to resolve these disparities than any other single social policy. But they might not solve the ways that the medical system treats Black patients with skepticism and hostility, the ways that doctors, for example, devalue Black pain, or the ways that the development of new drugs and surgical procedures still often relies on experimenting on more vulnerable patients in order to reduce the risk for everyone else. And they might not really solve in a satisfactory way the deadly consequences of environmental racism. So the way that wealth lets you buy your way out of air pollution, for example, is by moving. But while the right to move freely has always been one of the fundamental civil rights struggles in the United States, we might also wish to embrace a right to stay where you are, to stay where your history and your family are and have that be safe. Health reparations could encompass programs like the mass expansion of medicine through training doctors and nurses of color. It could encompass mass environmental cleanups, a kind of reparations at the community level. And you can be forgiven for finding this call for reparations for stolen time to be unbearably vague. And there's a sense in which that's intentional on my part. Because when I look at what we know about what changes during the 20th century made the greatest difference to narrowing inequality, and this is something I'm in the middle of doing systematically, but I'm not done, so appropriate caveats, right? But the thing that stands out to me is that they cross-cut some major dimensions of how we tend to categorize social policies. So there are things like desegregating schools, creating Medicare, New Deal public funding in the South. And those things should be maybe setting off bells for you, because something that's really weird about them as a set is that one is explicitly anti-racist, right? Desegregating schools. One is a universalist social policy, Medicare, and one is a supposedly universalist policy that was designed and implemented in some actually very racist ways. That's the New Deal. And our best evidence is that all three of them really mattered a lot to improving Black survival. But one thing that they all have in common is a radical scale of action. And so more than any specific policy, that approach is what I hope we will embrace. Racism produces a pandemic's worth of needless deaths every single year. That was true a century ago, it's true today. So our tools for fighting it should be pandemic scale tools as well. Our imagination and social ambition should not be limited by how accustomed the United States is to profound racial inequality. Instead of asking, what's realistic, we should change the question and simply ask, what will work? Thank you.
Thanks so much, Dr. Wrigley-Field. I really appreciate the journey that you took us on, and definitely the thoughts that you left us with about what we can do to potentially address the disparities that you presented. Lots of food for thought. And so I now open it up for the session for questions and discussion. And I did see one question in the chat from Jamila, and she said, has there been research that took into account reports of deaths that were underreported or reported as something else? And this is when you were presenting your flu work.
Yep. Okay, so in the flu context, yes, we worried about this a lot in that project, and we tried to think about what would flu deaths have been reported as if not the flu. So one thing is we include bronchitis death. We include pneumonia deaths as flu deaths. Pneumonia was actually the proximate cause of death for most people who died of flu. And then we thought, well, what else might you be diagnosed with? What about bronchitis? And so we also tried including those. it doesn't really change the pattern. We also find a similar but somewhat attenuated pattern in total mortality. So if you just look at all deaths, it's also true that the racial inequality in that year it existed, but it was a lot smaller than in every other year. We also think that the pandemic was just so salient that the underdiagnosis might have been more limited, but you might also be skeptical of that because we're living through a very salient pandemic where actually there has been a lot of underdiagnosis of COVID deaths, and there's great work by Andrew Stokes and others kind of suggesting that there's a real political dynamic to that. So for example, where you see a lot of excess mortality but very low official COVID is in counties that have higher Trump support. And we live in a US context where death reporting is very decentralized and often very deprofessionalized. So there's a lot of room for that. And we can talk more about underdiagnosis of COVID deaths if you want, but that's the 1918 answer.
Okay, Donna, I see your hand up, but before we do that, there's a related question about what source do you use for the 1918 mortality data by race? I thought that would be good to piggyback.
We use vital statistics. And so all of these are data that are at the city level. They're separated into what were at the time called white and colored. And they list cause specific data. And there's something like 30 specific causes. So influenza is one, pneumonia is one. Those are the two that we count. The other really big killer of the time, especially in non-white urban populations, was tuberculosis. And then there's a lot of other things, some of which from a modern perspective maybe make more sense than others.
Great, thanks. Donna?
Yes, okay, so I wanted to make one point about the vital registration because in 1918, 1919, it was based on reporting areas, and they weren't the same reporting areas across the country as we would see today. So there may have been, and then it was based on the quality of those vital records. So I think the question about underreporting is a really important one because you're going to be underreporting in some of the very areas where you see the greatest racial discrimination, particularly in the South and other areas that weren't part of the reporting area. But I wanted to raise a question that struck me in terms of one of the differences, and I think it's implicit but less explicit in your presentation. And that is that during the 1918 and 19 pandemic, it was an influenza virus and flu was endemic in the US population at that time, which is what I think you're describing in terms of the previous 20 years before and what would have been deaths related to a fairly virulent flu. COVID is a novel virus. So to what extent do you think some of the differences that you're raising, and I think you've implicitly said that, but are you explicitly really talking about the notion that when a virus is more endemic and there's been an experience with that virus, both historically and during the life course, as well as in the early part of the pandemic, that's one of the reasons why you see these reduced inequalities, whereas with a novel virus, it really highlights the really critical racial disparities in the country.
Thank you for this. So first, quickly on the vital registration. Yes, so these are not a nationally representative group of cities, nor an exhaustive group of cities. They're cities that were trusted by the National Vital Registration System to provide accurate data. And that means that they were disproportionately in the Northeast and Midwest and disproportionately not in the South. This is important, but I think it actually is less important for understanding the total racial disparities than we might think. And that's because the racial disparities were very extreme, but also pretty similar across regions in this time. So we did, James Feigenbaum, Chris Muller, and I did a decomposition of the overall regional differences in mortality. And we found that it was really driven by just the proportion of the cities that were non-white. And that's because this white, non-white differential was actually very similar across all cities. And what changed was just how much of the population was in each category. In terms of the endemic versus novel viruses, this is a really helpful thing to make explicit. And so I think I really appreciate this comment. And you're right that it's particularly when a virus is endemic that these life course histories of exposure are so meaningful. I think what I want to emphasize, though, is that they're not always going to be meaningful in the same way. And there's so much historical contingency that's built into this idea that, that it's because the Black population at this time that's living in cities is one that started out their life in rural areas and then migrated. And then once they were in cities, because of segregation and race and just really extreme racism, had to live in conditions that then gave them extremely high flu exposure every year. Like, that's a really particular history that is not sort of intrinsic to racial inequality generally. It's the way that racial inequality played out in this particular moment in time. And so in a way, what we're saying is there's a sort of massive historical coincidence here, if this story is right, where this really weird history of how people migrated and how they were treated in the different places that they lived lines up with this very particular history of how one kind of flu was replaced by another kind of flu that was so different. They're from two different phylogenetic lineages, that the immune system that was primed to respond to one could not mount an effective response to the other. And so, that to me is like, that's why I call it a cautionary tale against the idea of thinking that we can see some sort of universal path of how inequality will play out in pandemics. There's so much here that's so deeply historically contingent.
Thank you. I was just going to make one other comment, and that is H1N1 more recently. And the epidemic, or what was somewhat of an epidemic, what was it? I'm trying to remember, back in 90s. And where that, since you're talking about an H1N1 virus in the 1918-19, we had a repeat of one in the 90s, and I wondered if you had done some comparisons there.
I have not done any work on that. There is really interesting work in the immunological imprinting literature more generally about how the age and, well, really it's the cohort patterns that you see in more recent flus kind of reflects early exposures in ways that it's kind of surprising. Like it matches up better than you might think if you think about how much is changing for different cohorts. But it seems to actually really matter what flu you're exposed to first in your life for how your body is going to respond for the rest of its life.
Thank you.
That's fascinating. Jamila, did you have something else to say? I see your hand raised, and then we have a question in the chat that I'll state after.
One of the things I've been thinking about, especially about reparations, is understanding that the system is working kind of the same way it was a couple of years, 50, 20 years ago, that there's still things placed in the system that will make reparations not work as well as we think it would. For example, what I think about automatically is thinking about how schools are funded through property tax, and how many school systems, if the neighborhood is more low income, it's harder for the school to get funding. So when thinking about reparations, especially towards time and money, how can, as like a public health professional, can you think about balancing reparations and the fact that barriers are still there? And will these reparations go around these barriers, or do we have to do even more reparations to get over these barriers, or like completely, I guess, abolish these barriers?
Before you jump into that, there's a related question in the chat about advocacy. How do you plan to leverage this research for advocacy, particularly if it could be used to influence the reparations debate? So if you want to tie that in as well.
Thank you. These are both really important questions. I don't believe that there is any single policy, even a very comprehensive and radical and far-reaching one, that is going to comprehensively dismantle racism in the United States. I think it's too deeply baked in to the structure of how the United States works for that to be true. I also think that it's true, though, that some of the most far-reaching policies that were enacted in the 20th century, all of them in the context of tremendous social struggle that won them over profound opposition, and opposition is really a euphemism, often like profound violence, made a genuine and meaningful difference to how long people can live and what the quality of their lives is like. So desegregating schooling, which has been to a large extent undone in many of our lifetimes, it also really mattered for the quality of lives that whole cohorts of people had. Medicare is, I think not having Medicare is sort of unimaginable for many of us now, but it's not always widely appreciated the extent to which that was won out of the civil rights movement and anti-racist organizing to improve health. And so I think to me the question is, or I don't want to say the question, but I think a question to ask is, what's an approach that we can adopt to thinking about change that doesn't start out by straitjacketing us by saying, well, we want to only talk about things that we can imagine being sort of immediately plausible, right? Like abolishing slavery was not immediately plausible. Neither was abolishing Jim Crow. Neither was enacting major policies like Medicare and Medicaid, but they became imaginable through a mass struggle. And I think to me, like the thing that I sort of keep coming back to is, if we want to have the vision, if we want to start from the vision that nobody should be living longer than anybody else because of your race or your social class or your social origin. So what does that mean that we should be willing to embrace? The answer is that we should be willing to consider really profound changes in the same way that we were willing to consider really changing the way we live our lives in the context of the pandemic. So that's, to me, it's really about sort of like insisting on that as a starting point, instead of the starting point be, what can we imagine today, right now?
My first comment is thank you for a great lecture, stimulating and just endless questions. Several, but two that I listed. One is the cytokine storm issue and the youthful appearance in the 1918 pandemic led me to wonder if the increased young adult infection rate and morbidity and mortality in the subsequent waves in the current pandemic might have to do with their having come in contact with the virus early on, and subsequent contact led to cytokine storm. That's just a question that stimulated by your presentation. If there's time, I would add, in the 1918 pandemic, the military were important. It was an important element in the distribution of the virus. And I was wondering if there were disproportionate levels of infection that meet the white-black criteria that you were talking about, had to do with the segregation or distinctions that existed in the military.
Thank you. These are two great questions. I have not seen anything about the COVID pandemic that suggests that deaths that are happening now are driven by over responses to second infections. So, I'm not a clinical researcher, so that's not my area of expertise, but nothing that I've seen suggests that. It does look like it's exposure. It's really first exposures in particular, and also just exposures in total that are greater among relatively younger people now, partly because of differences in contact patterns and partly because of differences in vaccination, where older populations are much more likely to embrace vaccination regardless of other factors that otherwise might lead them to reject it. In terms of the military segregation of troops, I actually was really expecting to see an effect of proximity to military bases on these racial differences in the 1918 experience across cities. And we were a bit surprised not to find that at all, because it is such an important part of how that pandemic spread around, just troops moving. So your question about the racial segregation inside the military and how that might have contributed is a really interesting one. And I don't have a direct answer to it. I know that there are some data on, like the military collected its own data on flu deaths among soldiers. There's a really great review paper by Auckland and Mamaloons that goes through some of these different insurance data, military data. So that's where I would look for a better answer than I have.
Well, you stimulated us to think further. I would add, I loved your point about reparations and starting differently, because the with the Johnson response with Medicaid and Medicare, one sees extraordinary plummeting in not only on a racial level but on an economic level, because that really cross-cuts your 2 points with regard to the impact of moving from about 60% poverty down to about its current levels, which have been relatively constant at 10%. So kudos for a great lecture. Thank you.
Thank you. And I think that point is really right. You know, there is a tendency, I think, sometimes to put race and class in a certain amount of opposition to one another. But it's worth keeping in mind that the United States has worse outcomes for poor white people on almost every measure than our kind of economically peer countries do. And that's that should be a part of our thinking too, about the losses of early deaths.
You made my day, because I've argued that with very little acceptance of that particular point. Thank you.
Thank you.
I will jump in, and I'm going to ask about, or if you have some time to discuss some of your vaccination related work, including maybe just briefly talking about the paper that you recently published. Yeah.
Sure. So I was part of a paper that it's a team from Minnesota and California, which are 2 states that had early death certificate data, but also 2 states that have really different demographics. So it's kind of 2 helpful cases for asking what is the consequence of approaching vaccination in the early 2021 when vaccines were still scarce by age, so going oldest to youngest. And our starting point was that thinking about age makes sense because COVID is incredibly age sensitive, but also there's a certain kind of trade-off because white populations are older than populations of color, and COVID mortality gets high at younger ages in populations of color than white populations in the United States. So we wanted to know, what is the consequence of doing vaccination by age? And based on our analysis, we end up arguing that age-based vaccine prioritization in practice prioritized lower risk white populations above higher risk populations of color. So we found, for example, that if you eliminated all deaths above age 65, you would eliminate 2/3 of white COVID deaths, but less than half of Black and Latino deaths in these 2 very different states. One way this looked in practice, so here in Minnesota, where I am, in mid-January, the state said COVID mortality is so high for 65-year-olds that if you're 65 on up, you should be vaccinated right now, and everyone else has to wait. But we found that people of color who were as young as 50 had higher COVID mortality than that state aggregate that was 65 and up. So essentially, people of color who were 15 years younger were more at risk, but had to wait in practice 3 months longer to get vaccinated. And so that was the starting point for this article. And then we also looked at, could we imagine using geography in different ways and combining geographic targeting with age targeting to do better? And we end up arguing, yes, you can, although geography doesn't really work in general, as well as directly targeting age, race and ethnicity alongside age would have. We were very involved in trying to translate these research results into practice. So way back in February, I was presenting the early versions of the results to health systems here. And it was a really interesting experience because it made a big impact on their thinking. And it was partly because they're all clinicians. And so they're used to thinking about individual risk factors where you kind of think about them one by one, like, oh, age. And they're very used to not thinking about how there are population relationships, like, yeah, age matters, but so does race. And they're in some tension because older people are whiter and younger people, you know, are more racially diverse. And so that was just a really interesting experience to kind of see how that played out in their thinking.
Thank you for sharing that. Dr. Wrigley-Field, if you have any closing remarks. Hopefully,
This is a great audience. Thank you so much. I'm pleased to get to talk about both halves of the talk. So thank you for all these comments and questions.
yeah, I learned a lot. I said in the chat, I learned a lot about the 1918 flu. So that was really fascinating. And I got a private message from Emmy, and she's just really appreciative of how you integrated demography into public health. So we're always trying to make sure students see the importance of that. So thank you so much.
Thank you. Well, then in that case, maybe I'll end by saying, you know, I'm a formal demographer, which is mathematical demography, and it has a reputation of being very dry. But I think it's actually a really powerful tool for thinking about social inequality and social change. So that's just a plug to the students to think about learning it.
It's great. So thank you everybody for joining us. See many of you next Wednesday, and special thanks to Dr. Wrigley-Field for a great presentation. So thank you.